So, hi everyone. Thank you so much for joining our seminar today with Dr. Maurice Heiner on the topic of how to make a diagnosis on sleep apnea. And during the presentation, the attendees will be muted to avoid making any random noises that might distract the presenter. If you have any questions during the presentation, please pop them in the chat box below, and we will attend to them during the Q&A session at the end. So today we have Dr. Maurice Heiner, who is a respiratory and sleep physician. He has a particular interest and extensive experience in intensive care units, having formed ICU committees and founded Modern ICU in Brisbane. Dr. Heiner underwent extensive respiratory and sleep training in Australia, Canada, and the US, and holds licenses to work in all three countries. He is a founding member of the Asbestosis Research Group, Wesley Research Institute, an advocate advisor to the Department of Veteran Affairs, and an associate professor of medicine at Bond University. So over to you, Dr. Heiner.
Thank you very much. Good morning, all. There was a little confusion here in the last week or so about whether I should talk about making a diagnosis of sleep apnea or the problems that are occurring in orthopedic surgeons after surgery. So I hope I've got time to cover both. So firstly, we'll talk about sleep apnea. Now, apnea is the cessation of airflow. So if a person's not breathing, we say he's apneic. The difference between the apnea of sleep apnea is there is cessation of airflow, but the muscles of respiration still make an effort to breathe. Apnea can be divided into two types, central and obstructive. Central means that the apnea is caused by a problem in the respiratory center in the brain and or some other part of the brain. Obstructive apnea occurs when people have an obstruction peripherally. A hypopnea, think of a hypopnea as being a little breath. To be defined as a hypopnea when we're marking a sleep study, the airflow has to be 30% or less of normal. It has to last for 10 seconds, and it has to be seen to cause a problem in the sleep before it's counted as being significant. Now, the incidence of sleep apnea, you'll read various numbers in various articles, and that is because if you're looking at 1,000 obese fat men, the incidence may be about 80%. But the overall incidence that was recently recorded in a study in the United States was said to be about 14% in men, in 5% in women. The take-home message is this, that in a stroke unit recently, 60% of all patients who were admitted with stroke were in fact people who were suffering from and not being treated for obstructive sleep apnea. Now, I thought we should just define some of the things that you're going to see when you read about sleep apnea. Sleep fragmentation means that repetitive EEG arousals, particularly during REM sleep, is occurring because of some type of problem in the sleep. And hence one fails to achieve prolonged restorative sleep, and hence sleep fragmentation, which may be caused by snoring without severe obstruction, is very important. AHI stands for the Apnea-Hypopnea Index. It's also called the RDI, the Respiratory Disturbance Index. A normal value is 5 per hour or less when the person is asleep. Anything above 5 is abnormal, and the higher it is, the more severe the sleep disorder. The definition of fatigue is that people feel tired, listless, and lethargic, and that may be due to physical or psychological reasons. Sleepiness means that people can fall asleep at the drop of a hat, whether or not it's conducive or non-conducive situations. The important thing is, of course, that we don't want people falling asleep when they're driving, piloting a truck or an airplane. And circadian rhythm, the body has many factors which are controlled by a circadian rhythm. Circadian rhythm and sleep architecture means when one goes to sleep and they're sleeping correctly, a sequence of events occur in a particular manner. And if that sequence of events is upset, then people don't sleep well. Frequently, people who have sleep apnea, once treated for the apnea, there's a second problem, and that is restoring sleep architecture to its normal range. The symptoms of sleep apnea, well, snoring, obviously, excessive daytime sleepiness. When it comes to snoring, if the sleep partner has moved to a new room because of the snoring, I think that's a sign that this is very excessive and serious. There's an increased risk of hypertension and cardiovascular disease, and in fact, essential hypertension in young people, a term that's often used when there's not an obvious secondary cause, is now always checked and now is always reviewed and determined whether or not the patient has hypertension or sleep apnea. Because if a person has sleep apnea, the blood pressure may increase, and once treated, the blood pressure returns to normal. Neurocognitive impairment and even dementia can be associated with severe sleep apnea. There may be metabolic consequences, people gain weight, and of course we've mentioned stroke. So stroke and perioperative complications, very important. So what do we do? What do we do when we do a sleep study? Well, this is what we do. It's a multi-measure study. We look at the EEG, we look at the electrocardiogram, we look at flow in the nose and the pharynx, we look at muscle activity in the legs and the abdomen and the chest, so that we can accurately stage the sleep and determine the event. But the very first thing we do is we measure sleep latency. Lights out, room dark. Now, most people go to sleep in 10 to 20 minutes. If in fact they go to sleep in less than 10 minutes, usually means they're very tired. And if it's in greater than 20 minutes consistently, by definition, that is insomnia. Now, insomnia, many causes, but it can be divided into primary, meaning patients can't go to sleep, and secondary, meaning they go to sleep, wake up after a short time, and then have a problem going to sleep again. Now, once asleep, the first thing that happens is people go into what's called non-REM sleep, non-rapid eye movement sleep. In non-REM sleep, people do not dream. It's divided into 1 through 4 groups, and 1 and 2 are very light sleep. 3 and 4, people are in a deep sleep. Some of the new classification only states that they have 3 stages, but that's really immaterial. To sleep well, people need to have cycles of non-REM and REM, each cycle lasting 60 to 90 minutes, 4 to 6 cycles a night. Interestingly, as the night progresses, the cycles become shorter and more REM sleep is noted in each REM sleep in each cycle, so that early in the morning, nearly all sleep is REM sleep. RDI, of course, as I've said, means the respiratory disturbance index. If it's less than 5, we know the patient's sleeping well. If it's greater than 5, we look for a reason. Now, obstructive sleep apnea, other than hypopneas and apneas, all associated with decreased oxygen and an increased CO2. And often people say that people who sleep with apnea sufferers say they get very worried as they watch their patients or their loved ones stopping breathing and lying there motionless. if in fact, obviously they can't lie in motionless for a long time, because if they do, they end up DIB, dead in bed. So what happens is the bed partner usually shakes them, pushes them, punches them, does something to try to get them sleeping again. As the arousal, sometimes the arousals are very, very difficult. And what happens is that the respiratory center, or the brain, gets a message: not breathing, oxygen low, CO2 increased, do something. So these patients often sit up. Sometimes they regain consciousness when they sit up. They're always short of breath. They may be coughing. Sometimes they fling their arms and kick their legs around and can be very, very active, sometimes unprovoked. Assault of their patients, of their partners may occur as they fling their arms around. And this is how the body tries to get people sleeping again. And what happens here is that you get marked sleep fragmentation, you get no effective sleep, and the cycle interruption results in a diagnosis of obstructive sleep apnea and consequences. So the take-home message is that that cycle, REM to non-REM and then non-REM to REM, needs to continue uninterruptedly with a respiratory disturbance index of 5 or less, or very close to that, and you then know that the patient's sleeping well. So prevalent studies suggest that 40% of patients experience significant sleep disturbances following orthopedic surgery. I should have signaled that I'm now going to talk about orthopedic surgery. But before that, when you have people who have sleep apnea, they need to be treated. And altering position in bed, and the old farmer's method of tying and putting golf balls and tennis balls into the back of their pajamas just doesn't work. And we now know that if people have severe obstructive apnea and they don't treat it, in 20 years, they're all dead from all causes. So it's a very important thing to look at. Now, let's talk about orthopedic surgery. Studies suggest that 40 to 70% of patients experience significant sleep disturbances following orthopedic surgeons. Many of these patients have sleep problems which begin before surgery due to pain, anxiety, and worry, and worsen in the immediate post-operative period. The types of sleep disturbances include insomnia, patients lying there and not being able to go to sleep because of pain; fragmented sleep, meaning they're waking constantly because they can't find comfort in bed, or they have pain or worry. Hence, there's a reduced total sleep time. They have decreased REM sleep and slow wave sleep, or deep sleep. Now, the important thing about REM sleep is the REM sleep changes occur in the sleep, but they occur throughout the body. The important thing is that it's during REM sleep that people dream. So you should always ask people, do you dream? Can you remember it? Because if they don't dream and they're tired, they very well may have sleep apnea. And these people who have had operations also have circadian rhythm disorders because they've been constantly waking up and down. So the contributing factors to orthopedic problems are these. There's post-operative pain. It's often considered the primary cause of disrupted sleep. Yang and Company, in a paper in 2021, did a retroactive analysis, and he didn't find that pain to be independently significant associated with sleep quality. There was always problems associated with the pain. As I've said, opioid use and painkillers can suppress REM sleep, therefore decreasing effective sleep, and fragmented sleep architecture leads to the patient waking up saying, I didn't sleep a wink. Noise, it's very important to have the ward quiet. without, some wards, particularly surgical wards, do sound like a brass band at occasions. So noise, light exposure, frequent nursing checks to check IV lines, etc., are all capable of disturbing the patient. Anxiety and fear of re-injury or depression may worsen sleep, and surgical trauma in itself results in inflammatory cytokines, IL-6, tumor necrotic factor, etc., also disrupt sleep regulation and interrupt sleep. Now, so the clinical implications of postoperative sleep quality is associated with delayed healing, worse pain outcomes, increased analgesics and opioid use, slower functional recovery, and of course, in many patients, when they're lying around and they're tired, they may be at risk of developing deep vein thrombosis and pulmonary emboli. So, to summarize, the onset of the problems associated with sleep, there's an immediate postoperative period when this usually occurs. The sleep deteriorates from the baseline. It usually resolves in weeks, particularly when the surgery is minor, and 20 to 30% persists beyond 3 months. Pain, opioids, hospital setting, inflammation, and stress all add to the insomnia. It seems to be worse following hip and knee replacement, spinal surgery, and fracture repair. It affects healing, pain, mood, and rehabilitation outcomes. And it's thought, though I haven't seen a definitive paper, that if in fact patients are mobilized immediately after the surgery and the rehabilitation unit starts working on the patients immediately, then the sleep outcome is better. So that's a quick outline on sleep, how to diagnose sleep apnea, and of course the sleep problems related to orthopedic surgery. I think it's a good idea if people are going to have orthopedic surgery to make sure that they have lungs which are in good health, the COPD and asthma is well controlled, and it's important to ask about sleep and document it, and even do a sleep study if necessary. Sleep studies nowadays are very easy to perform. They are very accurately performed as outpatients. And if you know that the patient has severe apnea, then you can carry out tasks to prevent the problem. The other important thing to mention is that if people are being treated with CPAP before any surgery, but particularly orthopedic surgery, they should be told to bring their CPAP machine to the hospital so that they can use the CPAP immediately after the operation. Thank you very much for listening.
Thank you, Dr. Heiner, for your presentation. We do have a question in the chat box, which I'll out to you right now.
Okay.
Yep, so it's from Adriana. And Adriana asked, do you have any advice for insurers when assessing liability for secondary sleep apnea, especially assessing the causative chain of work-related traumatic primary injury, weight gain, sleep apnea? Thank you kindly.
Well, one of the reasons I always mention finding, if possible, what their sleep was like before the injury or before the operation is important. Interestingly, frequently when people have a severe head injury, they sleep for longer periods and are tired and fatigued for a much easier period. And it seems as though the brain is resting while it heals. But the other factors that you mentioned certainly, I think, should be considered when if people aren't sleeping and they're suffering following an injury or an accident. I think that should certainly be considered when you're working out total disability.
Yeah. Thank you for answering Adriana's question. Adriana said thank you. And thank you so much for doing this, Dr. Heiner. I think it was a really thorough presentation. We don't have any other questions in the chat box, so I would say that this seminar is now done. Yeah, but thank you so much everyone for joining, and thank you, Dr. Heiner, for doing this with Mac.
Thank you very much.
Thank you. Thank you, everyone.